There is a pattern I have seen in the data that most cardiologists are not discussing with their patients. People who sleep fewer than 6 hours a night have a 48% higher risk of developing or dying from coronary heart disease compared to people who sleep 7 to 8 hours. People who sleep more than 9 hours have a 38% higher risk. The sweet spot is narrow, and the damage from missing it accumulates silently over years. But the total hours you sleep is only part of the story. When you sleep matters almost as much as how long. And what happens to your heart during those specific stages of sleep determines in large part how your cardiovascular system ages. Today I want to walk you through 3 cases that show how sleep was contributing to heart disease in ways that had gone completely unnoticed, and what changed when we addressed it directly. The first patient was a man named Robert. He was 66. He came in for a routine follow-up after a mild cardiac event 18 months earlier. His medications were appropriate, his cholesterol was controlled, his cardiologist was satisfied, but Robert kept gaining weight around his abdomen. His blood pressure required 2 medications to stay in range, and he told me he was tired every single day. Not the normal tired of someone who has worked hard, a grinding, never recovered fatigue. I asked Robert about his sleep. He said he slept fine. 7 hours, he thought. He woke up once or twice but went back to sleep easily. His wife sitting next to him made a face. His wife told me he snored loudly. She had moved to a separate bedroom 2 years before, and sometimes she heard him from down the hall go quiet for what seemed like a long time, and then gasp. Robert had no idea. He underwent a sleep study. The results showed severe obstructive sleep apnea. He was stopping breathing 81 times per hour during sleep. His blood oxygen was dropping into the low 80s regularly throughout the night. Every time Robert stopped breathing, his body interpreted it as an emergency. His sympathetic nervous system fired, cortisol and adrenaline surged, his heart rate spiked, his blood pressure spiked. Then he resumed breathing and the cycle restarted. 81 times per hour, night after night, for years, possibly decades. This is why his blood pressure was so difficult to control during the day. The hypertensive damage was being done while he slept, and no blood pressure medication was present to address it during those nighttime spikes. This is also why Robert was exhausted. He was never reaching the deep restorative stages of sleep because every cycle was interrupted before it could complete. We referred Robert to a sleep medicine specialist. He began CPAP therapy. 8 months later, his blood pressure was controlled on a single medication instead of 2. His energy had returned. His wife had moved back into the bedroom. His cardiologist told him the CPAP had done more for his cardiovascular risk than the second blood pressure drug had. The second case involves a woman named Carol. She was 63, recently retired, and had been told her metabolic numbers were heading in a difficult direction. Fasting glucose of 114, triglycerides elevated, mild hypertension. No diagnosis yet, but the trajectory was clear. Carol slept 6 hours consistently. She had done this for years, since her children were young and the habit had never changed. She felt she did not need more. She was not tired. She had adapted. The research on short sleep and metabolic disease is more consistent than almost any other association in preventive medicine. When humans sleep fewer than 7 hours, glucose regulation deteriorates, appetite-regulating hormones shift toward increased hunger, and the inflammatory response is chronically elevated. Ghrelin, the hormone that increases appetite, rises. Leptin, the hormone that signals fullness, falls. The result is that short sleepers are biologically driven to eat more, store more fat, and respond to insulin less efficiently. This is not willpower. This is hormonal physiology driven by insufficient sleep duration. For Carol, I explained that her metabolic picture was not simply a dietary problem. It was, in part, a sleep problem. Her body was running an 8-hour biological system on 6-hour fuel. I asked her to add 1 hour of sleep per night, going to bed earlier rather than sleeping in, keeping her wake time fixed. This is important. A fixed wake time stabilizes the circadian clock, which is the master regulator of almost every hormonal and metabolic process in the body. Over 12 weeks, Carol consistently got 7 to 7.5 hours. Her fasting glucose at her next labs was 97. Her triglycerides had improved. Her blood pressure had come down slightly. She had not changed her diet meaningfully. 1 hour more of sleep had produced measurable metabolic improvements that 6 months of dietary counseling had not. The third case is the one I find most compelling from a mechanistic standpoint. The patient was a 69-year-old man named Paul. Paul slept 8 hours. He was not tired. His cardiologist had given him a clean bill of health the year before, but he came to me because of an unusual finding. A heart rate variability device he was using for fitness tracking showed that his overnight HRV, heart rate variability, was consistently very low and had been declining over 2 years. Heart rate variability is a measure of the variation in time between successive heartbeats. High HRV means the heart is responding flexibly to the body's changing demands. It means the autonomic nervous system, specifically the parasympathetic branch, which is the rest and repair branch, is active and healthy. Low HRV means the sympathetic nervous system, the fight or flight system, is dominant even during rest. A sustained decline in overnight HRV is one of the most sensitive early indicators of cardiovascular risk that exists. It precedes clinical events by years in many cases. It reflects chronic activation of the stress response during sleep, which damages the endothelial lining of blood vessels, impairs vagal tone, and reduces the heart's ability to adapt to exertion. Paul was sleeping 8 hours, but his sleep architecture was poor. He was getting very little slow-wave sleep, the deepest stage, which is when the majority of the cardiovascular restoration and HRV recovery that happens during sleep occurs. His brain waves during sleep showed excessive time in light sleep and repeated microarousals, brief awakenings too short to remember, but long enough to prevent him from completing deep sleep cycles. Paul drank 2 glasses of wine most evenings. Alcohol suppresses slow-wave sleep profoundly. It reduces the time spent in deep sleep by up to 20%, even in moderate amounts. It also fragments sleep architecture in the second half of the night as it metabolizes, producing a rebound in the stress hormone response around 2 to 3 in the morning that disrupts slow-wave sleep and pushes the nervous system towards sympathetic dominance. I asked Paul to eliminate the evening wine for 8 weeks and replace it with something that supported sleep architecture. He was resistant. He had enjoyed this habit for 30 years. I told him to treat it as an experiment with a defined endpoint. 8 weeks later, his HRV had increased substantially. His slow-wave sleep had increased. He told me he felt better rested than he had in years. He also told me, with some irritation, that I had been right. Now let me explain the physiology that connects sleep to heart health in more depth, because understanding this mechanism changes how you think about sleep entirely. The cardiovascular system does not simply rest during sleep. It performs specific maintenance work that is only possible during sleep and cannot be replicated during waking hours. During deep, slow-wave sleep, the sympathetic nervous system quiets significantly. Heart rate and blood pressure fall to their lowest points of the 24-hour cycle. This nighttime dip is called nocturnal dipping, and it is critically important. Adults who do not show this nocturnal dip, whose blood pressure remains elevated throughout the night, have dramatically higher rates of stroke, myocardial infarction, and cardiovascular mortality compared to those who dip normally. The nighttime dip is when the cardiovascular system decompresses and blood vessel repair occurs. During this same deep sleep stage, the glymphatic system, the brain's waste clearance mechanism, is maximally active. Cerebrospinal fluid flows through the spaces around brain cells and flushes out metabolic waste products, including the amyloid proteins associated with Alzheimer's disease. This clearance is 50 to 60% more efficient during slow-wave sleep than during waking. Poor slow-wave sleep does not just harm the heart. It allows neurotoxic proteins to accumulate in brain tissue over years. Growth hormone is primarily secreted during the first slow-wave sleep cycle of the night. Growth hormone in adults is not primarily about growth. It is about cellular repair, muscle maintenance, and metabolic regulation. Adults over 60 who lack adequate slow-wave sleep have significantly reduced growth hormone secretion, which accelerates muscle loss, fat gain, and metabolic deterioration. The autonomic nervous system, through the vagus nerve, uses deep sleep to recalibrate. High vagal tone, strong parasympathetic function, is associated with lower resting heart rate, better glucose regulation, reduced inflammation, and reduced cardiovascular mortality. This recalibration happens during deep sleep. Chronic sleep disruption shifts the autonomic balance toward persistent sympathetic dominance, which over years produces the same cardiovascular effects as chronic psychological stress. I want to tell you what I do personally because I apply this information to my own life and I am specific about it. My first non-negotiable is a consistent wake time. I wake at the same time every morning, regardless of what time I went to bed. I do this because the circadian clock, which regulates cortisol, melatonin, growth hormone, and insulin release, is anchored by the wake signal, not the sleep signal. Consistency in wake time stabilizes the entire downstream hormonal cascade. I have done this for 7 years. My second practice is temperature management for sleep. The body needs its core temperature to drop by approximately 1 degree Celsius to initiate and maintain deep sleep. I keep my bedroom cool and I take a warm shower or bath 45 to 60 minutes before bed. This sounds counterintuitive, but immersion in warm water causes peripheral vasodilation. Blood moves to the skin surface, heat radiates outward, and core temperature drops more rapidly, accelerating the transition into deep sleep. This is consistently one of the highest impact interventions for improving slow-wave sleep that exists in the research, and it costs nothing. My third practice is light management. I get outdoor light exposure within 30 minutes of waking every morning. Morning light delivered to the retina at the right time sets the circadian clock precisely and triggers a cortisol pulse that, when properly timed, ensures cortisol is low when melatonin needs to rise in the evening. In the 2 hours before bed, I reduce bright overhead lighting and screen brightness. I am not evangelical about this. I use screens in the evening, but I manage the intensity. Bright light in the hour before sleep delays melatonin onset by up to 90 minutes, which delays sleep onset and compresses total slow-wave sleep time. I have no cardiac disease at 61. My resting heart rate is 52. My HRV is in the range typical of someone 15 years younger. I am not claiming causation from my personal experience, but I am practicing these principles deliberately, and the physiological markers are consistent with what the research predicts. Let me answer the questions I hear most often. Is melatonin helpful for sleep? Low-dose melatonin in the range of 0.5 to 1 milligram taken an hour before intended sleep can help shift circadian timing, particularly in adults over 60 who tend to produce less melatonin naturally. However, melatonin does not reliably improve sleep quality or duration. It is a timing signal, not a sedative. The high-dose melatonin products common in North America, 5 to 10 milligrams, are pharmacologically unusual doses that may blunt the body's own melatonin response over time. If you use melatonin, use the lowest effective dose. Does exercise improve sleep? Yes, robustly. Moderate intensity aerobic exercise, particularly in the morning or early afternoon, increases slow-wave sleep duration and reduces the time it takes to fall asleep. The effect is not immediate. Consistent exercise over several weeks produces cumulative improvements in sleep architecture. Evening high-intensity exercise can delay sleep onset in some adults by raising core temperature and cortisol at the wrong time. So timing matters. Should I be worried about sleeping too long? Yes. The U-shaped relationship between sleep duration and cardiovascular mortality is real. Adults who regularly sleep more than 9 hours have increased cardiovascular risk, independent of underlying illness. In some cases, long sleep reflects an underlying condition, depression, hypothyroidism, obstructive sleep apnea, rather than causing the risk. If you consistently need more than 9 hours to feel rested, it is worth discussing with your physician. What should I do if I wake in the middle of the night and cannot get back to sleep? Lying in bed awake for long periods teaches the brain to associate the bed with wakefulness, which is the opposite of what you want. If you have been awake for 20 minutes or more, it is generally better to get up, go to a low-light, quiet environment, and engage in a calm activity until you feel sleepy, then return to bed. This is a core principle of cognitive behavioral therapy for insomnia, which has stronger long-term evidence than any sleep medication. Is a sleep study worth doing? If you snore loudly, if your partner has observed you stop breathing, if you are consistently tired despite what feels like adequate sleep, or if your blood pressure is difficult to control, yes, absolutely. Sleep apnea is dramatically underdiagnosed in adults over 60, particularly in women, whose symptoms often present differently than the classic male pattern. It is treatable, and treatment has measurable cardiovascular benefits. Sleep is not a passive state. It is the most active maintenance window your cardiovascular system has. Everything that happens during those hours determines in significant part how your heart, your blood vessels, your brain, and your metabolism will function tomorrow, next year, and 10 years from now. You can control medication timing, diet, exercise. You can also control your sleep conditions, your sleep schedule, and the habits that either protect or destroy your sleep architecture. The research is clear, the interventions are accessible, and the cardiovascular benefit is real. Next video, the specific blood markers that predict cardiovascular events years in advance, and why most of them are not part of a standard annual blood panel. Subscribe so you do not miss it. This is Dr. Whitfield. Thank you for being here. Important: this video is for educational purposes only and does not constitute medical advice. If you have concerns about sleep apnea, cardiovascular risk, or sleep-related symptoms, please consult your physician. Do not change medications or medical treatments based on this video.